All right, everyone. Everyone ready to get started? So we're going to finish up the ophtho section here and then do our review for the first exam. Everyone hopefully will feel a little more at ease about the test. Maybe not. We'll see. Okay. We left off on the anesthetics. Is that correct? Okay, fantastic. So anyway, so how do our anesthetics work? Anyone know how they work? How does like a normal action potential occur, say like in a nerve sending a signal somewhere? Okay, so you see depolarization. What causes that depolarization? Yeah, sodium influx, right? So what would happen if I block that sodium influx from occurring? There's no action potential, right? So exactly. So if you have somewhere where there's like a painful signal being sent by blocking those sodium channels, you don't have any basic propagation of that action potential up to the brain, so you don't get that sensation. And that's basically how all of our local anesthetics are going to be working in the eye, or it could be anywhere else. Like if you use lidocaine and say a laceration that you're going to be suturing up, or if you're using ropivacaine and an epidural if you're in labor, patient in labor, things like that. Same principle applies. So we have two main ones we're going to see being used for ocular purposes. Actually, hold on one second. I want to make sure this is picking up my... Okay, it is picking it up. Fantastic. I'd hate to go through all of that and then not record anything. My mic settings got off. But anywho, so we have tetracaine, we have proparacaine as being the two main ocular anesthetics we're going to be using here. And when would you want to use those? Yeah, tonometry, just reading the slide. Yes, that is possible. Yeah, so anytime you're doing anything direct manipulation of the eye where you don't want that sensation to be felt, or if you don't want the patient kind of fighting you because of that sensation, then yeah, these topical anesthetics can be pretty useful there. In terms of reactions, they are tolerated fairly well. You might have a little bit of a burning sensation, but that should dissipate as the anesthesia sort of kicks in there. Very rarely will you see hypersensitivity. The other thing to note is that for, say, 10 to 20 minutes afterwards, the patient's not going to have any blink reflex, right? Because when do you normally blink? When you get that sensation, the eye's kind of drying out, and that will trigger off that reflex. But if you anesthetize the eye, you're going to find they don't have that, and so what could that be a risk for? Dry eyes, but also you dry the eye out. What else could happen? Yeah, so you could have maybe like a piece of dirt or something gets in the eye. You could see corneal abrasions, maybe risk for infection. This is a big reason why you never want to prescribe these for outpatient use, right? Because if the patient's self-medicating, they could be causing some big issues there over the long run. And actually, has anyone ever heard of the term crack eye before? Good, you don't really run in those circles. That's probably a good thing. So an interesting side effect of certain illicit substances, and this is specifically for crack cocaine, if you recall, I mentioned cocaine is actually a Schedule II substance, and one of its benefits is that it actually causes some local anesthetic effects. It blocks sodium channels just like these drugs do. And so we mentioned using it for ENT surgery and things like that. So what happens is these patients will be abusing crack cocaine. Anyone know what route you normally use crack cocaine by? Usually smoking it, right? So cocaine hydrochloride, or the actual powder, is usually either snorted or injected, but the crack cocaine form, the freebase form, is typically inhaled, right? So you basically would heat it up and inhale it. And so when patients do that, they actually have some of that cocaine vapor will actually come off of that and will interact with the eye. So what do you think that does? Well, anesthetizes the eye, and so they lose that blink reflex. And so you can have patients who are coming in with really nasty corneal abrasions, or they could develop infections and things like that. And that's basically due to that absent blink reflex. So a good reason why we don't ever prescribe ocular anesthetics. And one thing you may want to check in, if you have a patient with a history of cocaine abuse, this could be something you might find as well, kind of as an incidental sort of finding there, right? Yes, sir.
Does this still apply to the whole, you can put an eye thing in the ear?
Yeah, so we don't really use too many otic anesthetics anymore. There was some products we used to use. There's one called Aralgan, which they actually took off the market. They really didn't find a whole lot of benefits with it to use. So I don't know how efficacious this would be if you did apply it in the ear. Hard to say. Usually if you just apply it directly to the skin, I don't know that you'd see a whole lot of benefits there. Yeah, I don't know. I don't know if anyone's tried it or not.
For the LASIK surgery, do you do something like that or something versus stuff?
I would guess you would use something like this, something local, because, and again, you'd have to ask someone who does LASIK surgery more frequently. I imagine it's more of a local anesthetic, because systemically you'd have to use, you couldn't use like lidocaine or something like this systemically, because when we do that, it's actually used as an antiarrhythmic because it will have heart effects. Just like our nerves need sodium influx to cause an action potential, the cardiac cells do as well. So these actually can be considered like antiarrhythmics almost. And so for that, you'd have to use something like more like sedation. We'll get into meds like that, later on in the class. But I believe they just use local anesthetic. Does anyone can speak to their experience? Yeah. So.
I don't know the specific drops, but they give like 2 types of drops, and you start using 2 hours before. You also get sedated though.
Okay.
Or well.
Probably like some light sedation, probably some Versed or something like that. Yeah, I have no idea. But a quick search of UpToDate could probably give you some good information there as well, right? So, and again, I don't know all things. I wish I did, but I don't. So it is what it is. Anywho, right. So again, just make sure you're not writing prescriptions for these. You don't want patients to be using these on their own. Usually used in conjunction with our ocular anesthetics are going to be cycloplegic agents. What do these do? It's a cycloplegia. Yeah, they're basically going to be causing pupillary dilation, right? They're going to be causing mydriasis to occur here. This is used pretty frequently if you need to do things like a fundoscopic exam. If you have patients with like uveitis or ciliary spasm, you're able to loosen those muscles and cause basically the eye to dilate, and that can be very useful in some certain cases here. And so there's a couple of different ways we can do this. One way we can do this is to use an antimuscarinic. And normally when you think about the fight or flight response, sympathetic activation, things like norepinephrine would normally do what to the eye? Mydriasis or constriction? Yeah, usually mydriasis, right? Because again, you want to take in all that light because you want to see whatever aggressor's coming at you so you can run away, right, when you're really freaked out. On the other hand, when you have more that parasympathetic sort of mode and you're rest and digest, what do your pupils normally do? The more constricted, right? You see that miosis. So it stands to reason if acetylcholine is causing that constriction of the pupils, we can actually use antimuscarinic to cause the opposite effect. And that makes sense. We talked about a few drugs like carbachol and pilocarpine in the glaucoma section as being used to help lower intraocular pressure, but they cause miosis and they also cause a lot of vision problems for those patients as well. But these are going to block the muscarinic acetylcholine receptors, instead of mydriasis. A couple different things we can use here include drugs like atropine, drugs like cyclopentolate, and then tropicamide are all going to be considered cycloplegic agents here. We use these pretty frequently. We'll oftentimes, I guess in my case here, in the ER certainly we'll have a lot of exams we might need to do for patients. We'll use like an ocular anesthetic, and that way we can do things like fluorescein stains, which we'll talk about in a second. But one thing we do pretty frequently in the NICU kiddos, especially the really premature kids, one of the things we're looking for is retinal hemorrhage, and so we can actually, we'll give them cyclopentolate and tropicamide. There's a combination product that has that on there, and then use that in conjunction with tetracaine as an anesthetic, and we'll do a lot of those neonatal eye exams. So that's a pretty common thing we do in the NICU. But anywho, so really the big problems here is going to be photosensitivity. What do you think they'd be sensitive to light? Pupils are way dilated, right? So they can't regulate how much light's coming in, and blurred vision would be another common one. So as I mentioned with the fight or flight response, you could also stimulate norepinephrine and epinephrine receptors as alpha receptors in the eyes, and that would also help to cause dilation in the eyes as well. Typically, these are a little bit more short-acting, so when you think about getting your eyes dilated at the optometrist, usually the antimuscarinics are going to be much longer-lasting in terms of their effects. Sympathomimetics are going to be a little bit shorter-acting. So depending on how much dilation you need, how much time you need, the optometrist might choose one or the other. The ophthalmologist might have a different purpose there. So typically here, we're going to have things like phenylephrine. And we talked about phenylephrine before. Where did I mention that? I mentioned the ENT section at all? Yeah, so phenylephrine I mentioned oftentimes when you look at like Sudafed PE or stuff that's out on the counters or on the normal shelves in Walgreens or CVS, that's kind of their alternative to using pseudoephedrine to get the decongestion effect. But remember what I said about the efficacy of oral phenylephrine? Yeah, it's kind of crummy, right? It's not very good, so that's why I always say just go talk to the people behind the counter and say, hey, can we get that real deal stuff? Let me get that Sudafed. That pseudoephedrine. And so, but here by other routes, phenylephrine is actually a really good drug. So we can use it in the eye and get very good bioavailability. It's going to cause that dilation. Everything looks pretty good there. You can see some photosensitivity, like we just mentioned, and some conjunctival hyperemia. Other than that, though, very well tolerated. Now, fluorescein is a good one. Actually, it's kind of funny because when you have an electronic medical record system, normally, just like you would search for things in Google, like you don't always spell out the entire word. You kind of do a couple letters, and then the thing will bring up. I always have this one doc who always was like, "How do I spell fluorescein again?" I had to say F-L-U-O-R, and he's like, "Oh yeah, that's it. Every single time. Never could figure it out for whatever reason. But Fluorescein, though, you're going to see that this is going to be very useful for helping to do some of these ocular exams. We need to look for things like corneal ulcerations and abrasions, things like that. And basically, you're going to find this uptake in the eye, those areas where you see those abrasions actually happening there. Basically, just a dye. You can basically just kind of place it down in the cul-de-sac. Normally, come on a strip, place it down the cul-de-sac there, and then allow the patient to blink a few times, and it should be able to kind of coat the eye. And then you get your Woods lamp out, and you should be able to see any sort of pooling or abrasions and things like that. Typically, you're going to be using along with an anesthetic, so usually the burning sensation is going to be pretty short-lived for the most part. Think of Trypan blue. So sometimes when you have very specialized sort of procedures here, and this is going to be seen more like in the surgery realm when you're dealing with ophthalmology, we can use certain dyes to actually stain certain tissues preferentially. As an example here, here's one called Trypan blue, which we can use to help visualize the lens a little bit better. So if you need to do specific surgeries on the lens, this can help out those ophthalmologists doing that. And in some cases, you may actually find the staining last a while, so they may have kind of a crazy looking eye for a bit, but sometimes you can see those dyes being used for those purposes. Okay, so again, patient education, we talked about this previously. Remember what's the most important thing when using your eye drops? Wash your hands. Remember to make sure, try not to make direct contact with the bottle to the eye itself, because it can pick up germs and cooties and all that kind of good stuff. And again, that's the other big thing if you're using, say, a solution or suspension after you instill the drops. You gotta make sure to block off the nasolacrimal drainage. That way you get a little bit better contact time with the eye, and the drug's gonna work a little bit better in those cases there, okay? Typically, if you're gonna be using multiple drops, I recommend waiting 5 minutes in between. That will give time for the first one to work, then you can get the second one in there. So especially for patients who are needing like multiple drops for glaucoma, if they're using a beta blocker and a prostaglandin or multiple meds, at least give them 5 minutes to kind of give time for the first one to work before you wash it away with the second drug. Okay. Okay. So any questions on the ophtho stuff? Yes, ma'am.
On the fluorescein stain
Mm-hmm.
picture, would that be herpes or would those just be like corneal abrasions?
I don't know. I believe I probably, years ago, Googled corneal abrasion. That's the first one I probably found. So if I had to guess, I would say that, but I could not tell you definitively otherwise. It looks like abrasions to me, but again, how many fluorescein stains have I done and actually examined? Not very many. Turns out it's outside of my realm of expertise. I say I know what drug you need. Here you go, and then that's kind of it. So you'll find that pharmacists, while we do have a wealth of information, very little of it is actually practical. And so if you had to think about the one healthcare provider you would not want to be stuck on a desert island with, is probably a pharmacist. You'd be like, you need some antibiotics. I don't know where to find them, but you need them. You know. Anywho, okay, so let's move on. Let's do a review for our first test here. All right. Is everyone ready? No, why not? Test on Monday. I'm sorry? The Cahoots? Yes, I do. Yeah, I'll post that out there. I think I did it for pharmacodynamics too, didn't I?
Oh, sorry.
I guess you didn't need it, so there you go. Anyway, so please log in, and we will do this. While we're waiting, I do have a joke I heard recently that illustrates the importance of communication. There's once a man who was kind of the town dullard, kind of a not the smartest individual, and he wanted to get some work as a handyman, get some extra cash. So he's going around kind of to see if he can find any work anywhere. Goes up to this guy's house, knocks on the door, and the guy says, you know, what can I do for you? And he goes, hey, do you have any work for me? He goes, yeah, I could use you to paint my porch. And the guy says, oh, I can definitely do that. And so he said, well, how much? And he goes, I'll do it for $50. I was like, all right, sounds good. So anyway, guy goes inside his house, talks to the wife, and the wife's like, don't you think you're kind of taking advantage of him? $50 for the whole porch to be painted. Didn't you tell him that it wraps all the way around the house? And he goes, no, I didn't mention it to him, but he'll figure it out soon enough. So anyway, like an hour goes by. The guy, handyman, knocks on the door. He says, I'm all done. The guy goes, really? You're all done already? It's only been an hour. And he goes, yeah, I even did a second coat. And he goes, really? I mean, how could you do that with that little bit of time? You did the whole porch? And he's like, no, it wasn't a porch, it was a Lexus. So, communication is important in medicine. Anyway, okay, let's get, people can log in. Okay, let's get started.
Oh no!
Darn, better hurry up. Too busy listening to jokes.
I literally.
It's okay, I should see the code down there. All right, which of the following medications is going to work by inhibiting bacterial folate utilization? You guys can see the code down at the bottom if you need to join in, and it's on there on the back screen. Can you shift it up? Oh my goodness, everyone's. Is that better? Oh no. Is that a little better? Okay, let's stick with that. This whole thing here I don't really need. You. And remember, for time's sake, fortune favors the bold. Click that answer. If you're waiting until the last second, I recommend just going with the gusto. Right? Exactly. If you get it wrong, it's no big deal. This is a very low stress kind of situation. Right? Okay. So which drug is working through bacterial folate utilization? Most of you got that correct. So we have sulfamethoxazole trimethoprim, otherwise known as Bactrim. Remember, this is working on 2 steps of that pathway, right? So again, it's working in 2 steps to block the cells from utilizing the folic acid. What do you think is the consequence that could do if it was, say, working on our cells too? Right, there's a little bit of bleed over effect there. What do you see? What kind of blood dyscrasias could you see potentially? So you can see megaloblastic anemia can develop there, thrombocytopenia can develop, right? Because again, it can affect our cells too to some degree depending on dose and exposure. And again, this is actually going to work a lot like the drug methotrexate when we talk about rheumatoid arthritis and talk about cancer treatment. That'll come up. That'll be a big thing that's going to play a role there. How does moxifloxacin work? Yeah, remember it's a topoisomerase inhibitor, so it prevents that unwinding and it causes more strand breaks in the DNA leading to cell damage. That's good. How about polymyxin B? Yeah, it kind of just punches a hole in the cell membrane to kind of leach out all those contents. Good. And then azithromycin? Good. Protein synthesis inhibitor. Which ribosome was it? Don't memorize that. You don't need to know it.
I knew it.
Don't waste your time on that detail, right? Just move forward. Just know it's a protein synthesis inhibitor. Okay? Okay, the dinosaur's in the lead. That's great. This is my daughter's favorite animal in the entire world is T-Rex. She loves T-Rexes. Okay, which medication can result in Reye syndrome when given to a child with viral disease? So they're febrile, giving them something for their fever. What could treat this, or what could cause this, I should say? Be aspirin, ibuprofen, acetaminophen, or guaifenesin. Let me see if I can raise it up a little bit. Note that your test isn't a collaborative effort, so remember that.
Yeah, I work I did a lot of information.
All right, the correct answer is last chance. All right, very good. Perfect. Yes. Okay. So we have aspirin. So this is really the only drug that we have here on the list that can cause Reye syndrome. What else could do that potentially? Another product we mentioned in the lecture. Pepto-Bismol, right? Why is that? Yes, bismuth subsalicylate, right? So the bismuth isn't a problem, but the subsalicylate is the issue there. Does anyone know what kind of imaging abnormalities you could find for a patient taking Pepto-Bismol? It's kind of interesting. You can always tell if someone's had Pepto recently because the bismuth is radio opaque. So you find these little punctate marks all over in the GI tract, and you can actually see that. So if you ever see that, you can be, oh yeah, have you taken Pepto-Bismol recently? And they say, how did you know? And be like, magic, like that, right? Ibuprofen, what are we going to use that for? Pain, headache, fever. Yes, you can use it. Antipyretic, good. What else? It's anti-inflammatory, right? So pain, fever, anti-inflammation. Okay. How about acetaminophen? What do we use that for? Pain, fever, good. And That's it. Good. There's no anti-inflammatory action, right? That's the main difference between acetaminophen and all the other NSAIDs that we talked about, right? So it's not even an NSAID, but we kind of lump that together because very frequently patients are taking these at the same time. You can either cycle off of them one after the other, maybe every 3 hours. Sometimes they'll take them together. It just depends on the situation. And then what does guaifenesin do? The mucolytic. It's going to help to break up that mucus, help them to kind of cough it up. What's a good counseling point for that drug? Why? Well, it helps to hydrate it, right? If it's all dried out and really thick and tenacious, it's hard to cough it up. But if you get it nice and hydrated with lots of water, it's going to be easier to cough up. I know it sounds gross, but again, you want to get rid of that junk and help to breathe a little easier, right? Okay. Very good. Up next, a patient complaining of seasonal conjunctivitis would most benefit from which medication? Be brinzolamide, cyclosporin, bacitracin, or tetrahydrozoline.
Yeah, where's Chroma?
Where is the cromwell? Oh, it's not an answer choice.
We only have 2 seconds.
Oh, that one got goofed up? I'm very sorry about that. Okay. Again, to err is human, and I'm still human as it turns out. Anyway, so let's look at this. So what would you use brinzolamide for? That's one of those carbonic anhydrase inhibitors that we use for glaucoma. Remember, that's one of those things that help decrease the aqueous humor production. Okay. How about cyclosporin? What do we use that for? We're talking about ocular stuff, so this is going to be one of those ones you may see it used systemically for things like immunosuppression to help patients who have transplants, but for chronic dry eye, especially due to those autoimmune conditions, that's a really good one. It's an immunomodulator that will help to decrease inflammation and help with tear production, right? So that's Restasis was that one, okay? Bacitracin, what would that be used for? For like a bacterial conjunctivitis, you could use it for that, but if it's just seasonal allergies, really, then you wouldn't want to use that necessarily, okay? And then tetrahydrozoline, how does that one work? Remember, it's a vasoconstrictor, right? That's how it deals with that conjunctivitis. By constricting the blood vessels, you deal with that swelling, the edema, the redness. So that's really the best thing that's going to be doing for that. In terms of how long you can use that one for, what's kind of the limit, do you think? We usually say at least less than 2 weeks, if not even shorter, if you can. For something like Afrin, you're going to see like 3 to 5 days is usually the limit for that one. This one you may be able to use a little bit longer, but certainly longer than that. What do you worry about when they discontinue it? The rebound hyperemia that can happen with that, right? It can be worse than what it was even in the first place due to that downregulation that occurs there. Okay. Very good. All right, which fungal infection would require the longest treatment time, do you think? Would it be the fingernails, chest, toenails, scalp? What do you think?
Tell us the whole thing.
Longest treatment time. Get your last answers in. And let's see. It was the toenails. Why do you think that is? They're fairly slow growing, the blood supply to it's not going to be as high as it would be like to the scalp, so that's why you saw for things like griseofulvin, you may be treating up to a year in some cases, right? And so what does that do for compliance? It's going to go down, right, pretty significantly. So if you have to tell someone here, take this for the next year for an infection, like that's not going to be great. So in those cases there, the compliance is going to be a big problem. Fingernails would be, shorter than that, but still a long time. Scalp will probably be the shortest period of time, right? Okay. Very good. Yeah. You diagnose a patient with viral rhinosinusitis. Which treatment would be most appropriate? Foscarnet, valacyclovir, acyclovir, or supportive care? we think? Yes, absolutely, right? So the majority of viral illnesses, what do you tell your patients? Nah, I'm not going to give you anything, right? Can't do much for you. They said, but I have a virus. Why don't you give me an antiviral? It's not the right kind of virus, right? So again, typical adenoviruses and rhinoviruses and things like that, not really good therapy for it. What would acyclovir and say valacyclovir be used for most commonly? Herpes is a big one, right? What about foscarnet? That would be herpes as well, but it's really reserved for more kind of invasive viral infections, things like cytomegalovirus potentially, things like that could be used. And so that one's we hold off for and don't use very commonly. But yeah, supportive care for the most part, which is not great to hear, but you got to be able to educate on that.
You said varicella and shingles as well?
Yes, you could also use valacyclovir and acyclovir for that. Yeah, those are common ones. And what's the relationship between the valacyclovir and acyclovir? Which one's a prodrug? Valacyclovir, remember, why do we do it as a prodrug? Bioavailability is much higher with that one, for sure, right? If I was using an IV, which one would I give? Acyclovir, right? I can just give, if it's 100% bioavailability with IV, then I can just give the parent drug. It's no problem doing that, right? What if I put oseltamivir on here? What's the brand name for that? Tamiflu? Could I use that here? No, what's it used for? Influenza only, right? Very good. A or B? A and B, right? You can use it for both. Okay. Which medication is most likely to cause sedation as a side effect? Would it be cetirizine, fexofenadine, loratadine, or chlorpheniramine? What do we think?
Here's a good exam master question that was similar to this.
Yeah? So which one's least likely to cause sedation? I like to avoid like least likely and not and accept and things like that. All right, last answer's in. A few people not quite sure. It's okay. I'll make them sure. Very good. Yeah. So what's the first three answers here? What are they considered? What's their classification? Second generation antihistamines, right? So why are they unlikely to cause sedation? Can't cross that blood-brain barrier. Absolutely. Which out of those three, which do you think would be most likely to cause sedation? Yeah, Zyrtec is actually the one that's most likely. It's actually structurally related to which one? Hydroxyzine. This is one of those other antihistamines we talked about. That's the first generation. They share some similarities there, but less likely. But still, out of those three, that one would be the most likely to cause sedation. But certain chlorpheniramine being a first generation agent, absolutely, right? Why does it cause sedation? Right, but once it crosses, what does it do there? Remember the antimuscarinic actions, right? The antihistaminic actions, all that can lead to that sedation sort of effect, right? What other agents would be on that list of things likely to cause sedation? Benadryl, which is what? Diphenhydramine, good. What else? Promethazine's a really good one, or Phenergan, right? Dimenhydrinate, which is Dramamine. Meclizine, which is Antivert. What else? Doxylamine, which is Unisom, right? That one we use it, we market it specifically for sedation, right? For sleep. Okay. Very good. Which of the following antifungals blocks CYP3A4 activity? Ooh. Would it be nystatin, griseofulvin, fluconazole, or amphotericin B? Yeah, it's like preparation H. Like we just got to the second amphotericin and it was good. I have no idea. It's like preparation A through G didn't work so well.
Yeah, right.
Yeah. Why do you think I care which antifungal blocks CYP3A4 is its mechanism? And it's going to block our CYP3A4 too, right? So again, know your mechanisms. It's going to be the azole antifungals. Remember, see, posaconazole, itraconazole, ketoconazole. The azole antifungals are the ones that are going to cause inhibition of the CYP enzyme in the fungus, so that way you can't form that ergosterol. Here we're seeing they can affect us, and that's why we see so many drug interactions because of that, right? If you remember, amphotericin B was more forming that pore in the membrane itself and cause that leaching of all the contents, right? It's kind of like a cell wall active or cell membrane active agent for that one there, okay? All right. Which medication is first-line therapy for a patient with strep pharyngitis? Daptomycin, vancomycin, clindamycin, or amoxicillin? Yes, thank you. Some of these, if you ordered, you'd be getting a very strongly worded call from pharmacies. Now, what are you doing? Don't do that.
Yeah, that's only
Have you ever done that?
Have I ever done that? Had to make a call? Oh, yeah.
And there's 60 answers. What is this?
Oh, yeah. Yeah, no, because you know, they'll have an idea. Especially this happens more with residents, you see, but they'll make an order for something just totally goofy. And they're like, well, it'll cover it. And I said, yeah, it'll cover it, but like, how about all these other things that are way less expensive that'll cover it? And they're like, oh yeah, I guess we could go with that. I said, okay, that sounds good. Why don't you do that? And then they do it, and it works out.
Have you ever had to yell at one of your students?
Have I had to do that before I'm a student? If I have, there's usually a good reason they're doing it. So, for instance, I remember I had one person. I think they're from here, but they weren't one of my students. But they were writing for something kind of odd. I thought it was a little too broad, and so I called them on it because it was a very non-typical, like surgical sort of drug. I think they're ordering Zosyn for something. And I was like, hey, what's up with that? How come we're using that instead of X, Y, and Z drug? And like, oh, that was actually a recommendation from ID who had been consulted on the patient, and that's what they had said. So frequently, there's other conversations that are going on that I may not be privy to, but that's why I call and kind of ask the questions first, right? I don't want to go in and be like, no, this is wrong. Like, you get far more flies with honey than vinegar, as it turns out. So just go, hey, I was curious. What's up with that? Anyway, so looking at this, very good. No one chose daptomycin. That's one of those things I'd be like, no, it's like using a bazooka to take out a housefly or something. You don't need to do that. How about vancomycin, right? Would vancomycin work? Yeah, it probably work, but again, it's way too overkill, right? Especially for a strep pharyngitis. Someone's going to go outpatient. We don't need to worry. Now, could I use oral vancomycin for that? No. You maybe think because it's in the throat, maybe, but no, we don't do that, right? What do we use oral vancomycin for? C. diff specifically, right? And again, does it cause any systemic effects when you use vancomycin orally? Or no, because it doesn't actually get absorbed. Such a big molecule, it can't actually happen. Well, most of the time it can't happen. But how about clindamycin? Would that work? That would work, actually, right? So that would be a good backup if you had a patient who could not take amoxicillin. That's actually a very good one. And amoxicillin is usually going to be the first line for that. If the patient couldn't tolerate oral, what else could I do? I just want to use like a one-time dose of something. Penicilin, yeah, Penicilin LA is a really good one for that. We'll do that pretty frequently. Again, it's just a one-time dose for that, but again, the trauma of getting an IM injection for a little kid can be something to weigh against that, right? Okay. Which medication could cause iris discoloration? It would be tafloprost, pilocarpine, dorzolamide, or levobunolol. I'm going to discolor your iris. Every time I think of iris discoloration, I imagine like iris walking in purple or something.
No, I don't remember.
I think the timer is goofed up. But yes, tafloprost, right? So when you see prost, what do you think? Prostaglandin, right? Remember, prostaglandins are going to be the thing that will cause the iris discoloration. What else does it do? Cause your eyelashes to lengthen, right? So again, all those prostaglandin analogs are going to be able to do that, right? And they help with basically, they work on the production of the outflow. Maybe one thing you want to know, perhaps, right? We're working more on the outflow side of things, right? Help kind of open that up and allow for that the intraocular, the aqueous humor to drain out a little bit better. Pilocarpine, what kind of drug was that? Those ones cholinergic agents. It would cause meiosis, right, and allow for a little bit better outflow. How about dorzolamide? Very similar to brinzolamide, which we mentioned before. It's a carbonic anhydrase inhibitor. Okay, how about levobunolol? Yeah, if it's an LOL on the end of it, what does it mean? It's a beta blocker, right? It's like propranolol, metoprolol, atenolol, levobunolol, cardiolol, all end with that OLOL, all right? And so that's how you know it's a beta blocker, okay? All right. Alcohol avoidance should occur with patients taking which antibiotic? Metronidazole, cefazolin, linezolid, or acyclovir? This one's like standard board style question. Are you staring you down?
Short answer.
Very good. Flagyl, metronidazole. Do not want to take that with alcohol. Did I tell you about the pharmacist who was using topical Flagyl that had a reaction? Yeah, so one of my coworkers, his wife was actually taking topical metronidazole for rosacea, and she applied it. She was out of the Olive Garden. What do you drink at Olive Garden? Well, some of you might, but she also drank wine. May hit some of the sangria, perhaps, and it got super red, super flushed. People thought she was having a heart attack. No, it was just the metronidazole causing that local reaction, right? What do you call that reaction? Disulfiram reaction, right? Because you're inhibiting that breakdown of acetaldehyde. Okay, good. So cefazolin, linezolid, acyclovir, none of those issues. What would I want to be careful of taking with linezolid? SSRIs, right? Now, red wine specifically, you may want to avoid with linezolid. What other type of foods would you think about? The bougie foods, right? So your aged cheeses, not like your Velveeta slices, like that's not going to be it. Like your Kraft singles, no, you don't have to worry about that one. Decidedly not bougie, as it turns out. But like your aged meats, things like that, those are things you want to typically avoid there, right? Acyclovir, potentially you could think about like if you were, say, perhaps ingesting a few too many alcoholic drinks, you could get dehydrated. That could cause a problem with acyclovir. Because remember, it can cause like crystalluria. They can develop, basically, it will precipitate out in the renal tubules. But that's why we tell patients when they're taking acyclovir, stay really well hydrated. And it helps make sure you're flushing that stuff through the kidneys with little incident. Okay. Okay. Yeah, that is very true. Exactly. So it would not be correct just on that basis alone, technically speaking. And technically right is always the best kind of right. So I hear. Which of the following medications can prolong the QTC interval? Oof. Okay. Clindamycin, clarithromycin, ampicillin, or sulfamethoxazole trimethoprim? What's a normal QTC? Usually 0.44 seconds or 440 milliseconds. For men, a little bit longer, like 450 for females. What arrhythmia can you get if your QT prolongs too much? Torsades, good. What's the treatment of choice for that? Yes. Magnesium sulfate, IV, right? Very good. Interesting. You got a pretty even split amongst most of these. All right, so looking at this, remember, what were the two classes of antibiotics we talked about so far that were big for causing QTC prolongation? macrolides, and fluoroquinolones, right? Those are two big classes we talked about. How can you tell if something's a fluoroquinolone? Yeah, fluoxetine, right? So levofloxacin, ciprofloxacin, that's how you know it's going to be a fluoroquinolone. For the macrolides, how do you remember which ones are which? ACE, right? So clarithromycin, azithromycin, and erythromycin, right? Very good. But again, some of these can get confusing, right? When you look at clindamycin and clarithromycin, you're like, wait a second, I know it's ACE. What was the C? They both end with mycin, right? These are those distinctions you're going to have to make in your head when you're looking at this stuff on a test, okay? And again, practitioners get confused with this stuff all the time. They're just looking at, drug names off a list. They pick the wrong one, and it's how a lot of errors can happen there because things are look-alike, sound-alike kind of drugs, okay? Okay. Which of the following can cause bradycardia in patients with significant nasolacrimal drainage? So if you forgot to pinch off your nose after giving some eye drops, which one could cause this? Tetracaine, bromonidine, cardiolol, or latanoprost? I'm sorry about some of these timings. I should have double checked these. Usually I give a minute. But, right, so why is cardiolol going to do it? It's a beta blocker, right? So when you block the beta receptors in the heart, specifically which beta receptor? Beta 1 specifically, right? That's going to slow down the heart rate, and you can see that bradycardia there. Good. Tetracaine, not really going to cause any issues, right? Bromonidine, latanoprost is not going to cause any issues in terms of typical nasolacrimal drainage causing any kind of big issues there. What could cardiolol potentially be an issue for? What other type of patient would you be cautious about? Perhaps asthma. It's one of those things with selectivity, right? We said cardiolol is actually going to be one of the more beta 1 selective agents, but you still want to at least have that on the back of your mind. Hey, patient with asthma, they could have a reaction, but it's going to be lower with something like cardiolol. Because selectivity is always relative, right? You never have anything that's 100% selective for one and only one receptor typically. Okay. Tendonitis and possible tendon rupture is a concern for which of the following medications? Ciprofloxacin, clarithromycin, amoxicillin, or clindamycin? What type of patients does it happen more often in? Kids, right? Less than 18, typically.
Do you have a good gauge on which ones are going to answer right and which ones are not? Do you have a good gauge on which ones are going to answer right and which ones are not?
It depends.
Like you see this one, you think it could be the same as the last one.
This one, I think most people probably get it, right?
Okay, yeah. Well, because we've gotten this in at least one other class.
Exactly, yeah. That's the whole goal, right? We cover these things multiple times in different angles to try to help solidify that knowledge. That's why I gotta trust that process, right? We produce a lot of good PAs, and you guys are going to be exactly the same as all of them. Very good PAs. So.
Let's go.
None of you got in here by accident. Very good, right. So, as a class, what can cause the tendonitis? The fluoroquinolones, right, it can all do this, right? Cipro, levo, any of the floxacins are going to be able to do this here. Good. What would I worry about, say, for instance, like clindamycin? What's that really known for doing? Yeah, it can cause C. diff. What kind of bugs does it cover? Gram-positives and anaerobes, right? Gram-positives and anaerobes, which makes sense why it can cause C. diff. If you're getting rid of all the anaerobes, you could leave a pretty open spot for that C. diff to then start to proliferate, right? Very good. All right, which medication would provide gram-positive and anaerobic coverage for a dog bite? Hopefully I didn't give it away.
Yeah.
Vancomycin, tobramycin, ampicillin, sulbactam, or clindamycin? I don't like when the randomization sort of gets me.
Oh, David Levy says hi, by the way. He's delivered 5 babies.
He's dead to me now.
I'll tell him.
It's good for him. He just got married, so I wonder if it's like put him in baby fever mode.
It's a
Perhaps.
dangerous first rotation.
Or it's the right first rotation to prevent anything from happening.
Reproduction is not the goal. like freaking wrestling.
It's fun that you get to see like when the babies come out. It's like a all nice happy moment. But I wish you guys got to see like the moment when like they discharge you and they just say, "Here you go," and you're just like, like they make sure you have a car seat. They don't even check to see if it's like installed correctly, and they just say, "Here, make this thing alive and keep it for a while." Like it's just very bizarre. Yes, we actually had 2 correct answers here. And again, I'm only going to put 1 right answer on the test, so no worries about being tricked on the test here. But it's good to have your options available, right? You want to know what I can use as a backup in case something maybe can't be used in the first place. So vancomycin, what would that cover? Yeah, get MRSA and also get all your gram-positives you'd be worried about. Because when you think an animal bite, you're thinking the normal skin flora, right? And then you're also thinking the stuff in the mouth that could be getting into that wound. So vancomycin will get the gram-positives, but it lacks the anaerobic coverage you're looking for. What would tobramycin cover? Just gram-negatives, right? Including Pseudomonas, but it would not really cover any of this. So that would be inappropriate to use for this kind of case here. Maybe there is an odd animal that maybe would require it. I don't think of too many. Like I mentioned, if like an alligator bite, I think we use like Clinda or I think we use Clinda and like in levofloxacin or something as a weird combo. But with ampicillin sulbactam, why is that one able to cover anaerobes? The additional beta-lactamase inhibitor is helping it out, right? Because that helps to broaden out that coverage. Would I be able to use ampicillin by itself in this case? No, ampicillin and amoxicillin will not be good by itself for an animal bite specifically. It really doesn't have a whole lot of anaerobic coverage there. Yes, ma'am? 100%, yeah. You could maybe send the patient home with Augmentin depending on the severity of the bite. Sometimes they have to come in for surgery. That'd probably require more IV therapy. But if they're going home, then Augmentin would be a great option to send them home on. If they're penicillin allergic, though, you want to use that, that's when we can switch over to something like clindamycin. That would be totally appropriate for that. Okay. All right. Which medication should be used to treat acute otitis media in patients with a legitimate penicillin allergy? Choose linezolid, levofloxacin, ceftonir, or benzathine penicillin G.
Seems oddly familiar.
Probably heard something similar in Professor Q, perhaps. Possibly.
Alright. If I don't get this one right, then I get it wrong. It happens a lot, but not always. If you don't get it right, you get it wrong. It should be yellow, but it has like an orange feel to it. Like if you don't think that's like a blood orange, you're in denial.
All right.
It's straight up orange for me.
So let's look at this. So these cases here, linezolid, would that be appropriate? Why not?
Atomic bomb.
Well, it's not. Also, it's not going to cover all the bugs you're looking for, right? So what would be the 3 main top bugs on your list causing AOM? Strep, pneumo, H. influenza, Moraxella catarrhalis, okay? So those are the 3 big ones you're going to be seeing in terms of AOM, right? Could be other stuff, but those are the 3 most common. That's what you'd be treating for. Benzathine penicillin G, why is that wrong? Because they're going to be allergic to that too, right? They're allergic to penicillin. Benzathine penicillin is penicillin, right? If I'd said Augmentin on there, or amoxicillin, would that also be incorrect?
Yes.
Yes, because again, that's going to be class-wide sensitivity with those patients, their cross-sensitivity. How about levofloxacin, right? Why is that one wrong? Yeah, I started to see a lot of strep pneumo resistance with levofloxacin. So while theoretically it could cover it, depending on where you're practicing, what the kind of the rates of resistance are in your community, you may find that is not always going to get that strep pneumo because of that. So as an alternative, I mentioned ceftonir. Why is ceftonir okay to use? Remember, so it's going to cover all the bugs we're looking for. It also has a low risk of cross sensitivity with the penicillin, right? Very low risk of cross sensitivity, especially even if they have a true anaphylactic allergy, less than 1% chance. Okay. Now, if you're worried about it, what could you do? Yeah, you can try to give them a test dose in the clinic or in the ER, wherever you're practicing at. Give them a test dose, see how they respond. And then also just double check, like, okay, what kind of allergy did you have? What reaction did you have? Have you received anything like this before? If you have the ability to look in their past medical records and see their meds, that can be really handy to find out what they've gotten before. If they've had it with no problem, then keep going with it, right? Very good. The eggplant is now number 1. All right, patient with penicillin allergy would be contraindicated from receiving which medication? Piperacillin, tazobactam, meropenem, aztreonam, or ceftriaxone. That's why I put these in a random order, but somehow it just lumps up together like that. And get your answers in. All right, yes, piperacillin, tazobactam. Why is that? Still a penicillin, right? So even if it is, anti-pseudomonal, even though it covers that extra stuff, it's still going to cross-react, right? Because again, penicillin allergy is a penicillin allergy. So dicloxacillin, oxacillin, piperacillin, any of those, you're going to cross-react there. As Treenant, remember that one has like really no cross-sensitivity. Meropenem, also not going to have that. And then we mentioned the ceftriaxone. What class of medication is that? Which generation? Third generation cephalosporin. Again, very low cross-reactivity. So of the 3, that one would be the most likely to do it. But again, the chances are very, very small that it would actually occur. Okay? Yes, sir.
Like the real world, where, like you're saying, the chances are very small. And so would you put, like, in your chart that I'm prescribing this ceftriaxone or the cephalosporin, and because there's such a small activity,
Yeah, you could. Yeah, so you could certainly document that. So you could say in your chart, patient has reported penicillin allergy. For one, if you think it's not a true allergy, you can say, patient's reaction was, diarrhea was not a true allergy. You could say that. You could also say that if it was, say, a true type 1 allergy, say, based on literature, there's a less than 1% chance of actual cross-reactivity. So feel comfortable using a test dose in the ER and then going from there, right? Or what the case may be. Again, it doesn't mean that the patient won't have a reaction, but you're just trying to protect yourself with a documentation standpoint. You said, well, the very low risk, and they're saying, well, how do you know? You can say, well, I have this literature here that points it out. So you can look on UpToDate, you find the actual articles that do the reviews and actually show that there's a low risk, and that helps to support your decision to try that out, right? But you always want to have documentation for stuff you're doing. And should you believe anything that I say? You say, well, my farm teacher told me that. Like, who's your farm teacher? And like, well, that guy, he doesn't even know what he's talking about, right? So you always want to be able to look it up, or you want to be able to find that information and double verify what we're saying, right? Doesn't just because we say something doesn't mean it's real, doesn't mean it's true. I hope it is, but it doesn't mean it is. Just saying. I lost my pharmacy license a long time ago, and just kidding. I'm renewed for another 2 years, so I'm good to go. Mydriasis could be caused by which medication? It could be cyclopentolate, carbachol, Trypan blue, or fluorescein. We just covered this. It should be very fresh in your mind.
Right?
Very good. Yes, cyclopentolate. Remember, that's a cycloplegic. How does it work? Anti-muscarinic, right? Blocking acetylcholine receptors to cause the pupils to dilate. Carbachol would do what? Cause meiosis, right? It's going to be one of those acetylcholine receptor agonists in those cases there. Trypan blue and fluorescein, those are just staining medications, so that would not cause any issues with either of those, either mydriasis or meiosis. Okay. Very good. A mass of pills in the GI tract is known as what? This one's kind of a fun one. Fun bit of trivia. Is it a phytobezor? Is it a pharmacobezor, a trichobezor, or a tabletobezor? What do we think? It's in your fund of sort of esoteric medical terms. Yeah, it's actually a pharmacobezor. So if you had someone who had and so things that can cause this, we see sometimes we'll see this in overdose, like a massive aspirin tablets or iron tablets can actually form a pharmacobezor, which is kind of problematic because it can slowly leach off drug as it breaks apart over time. That can be a problem. What's a phytobezor? It's actually plant-based bolus. So if you had someone who's eating they have pica or something, they're eating dirt and plants and stuff like that, that could actually form a phytobezor. And how about a trichobezor? That's hair, yeah. So if they're like chronically eating their hair, again, this is weird stuff, but you can see that. So basically, they have a hairball, essentially, right? Tableto bees, I just made that up. So. Okay. Which of the following has coverage against MRSA? Gentamicin, cephalexin, polymyxin B, or clindamycin?
Stroke your beard, you'll find it.
What do we think? What do we think? And
Where the picture comes in.
okay, yes, clindamycin is correct. That does cover MRSA. What does gentamicin cover? Gram negatives only. Do you ever use it for gram positives?
No.
That's the point. I probably wouldn't ask a test question on this, at least on this test, but yeah, sometimes you can use it for intercoccal synergy by using it with something else like a vancomycin or penicillin or something, like for endocarditis. That's used occasionally.
You're saying like pair. You're saying pair it with just for coverage purposes?
Not specifically for coverage, but you get synergy. You get better kill for. So when you have endocarditis, you get this big vegetation sitting there on the valve essentially, and it's really difficult to penetrate and get all this bacteria. So by using that gentamicin plus something like a penicillin or vancomycin, sometimes you get better penetration and better kill. What?
I just don't quite get it, but I believe you.
It's just synergy. You get better activity than either one by itself, essentially, right?
Okay.
Yeah. We can talk later if you want.
Sounds good.
How about polymyxin B? What would that cover? Only gram negatives, right? It does include Pseudomonas, right? Gentamicin, will that cover Pseudomonas? Mm-hmm. Yep, it does. And then cephalexin, what's that going to be covering? What generation is that? First generation. Okay. Will it cover? It doesn't cover MRSA. Does it cover MSSA? It does, right? So again, that's why we like it for surgical prophylaxis. It's going to get most of that skin flora stuff that you might see introduced in surgery. Not cephalexin, but cefazolin, another first generation you might see there. So clindamycin covers MRSA. What else could I have put there that would have been true? Vancomycin, good. Daptomycin. Tetracyclines could potentially get it, yeah. Linezolid, yeah, that one of those 5th generation cephalosporins, which don't use too much. What else? Ticacycline variable, it doesn't always get that. Perhaps. Yeah, not VRE, but there's some MRSAs. What's another big one? Bactrim's another big one. Yeah, Bactrim, right? So at least get those main ones. Okay, very good. Okay, so moving on from that. I'm scared. Don't be scared. Don't be scared. It's okay. It's all good. All right. When dealing with time-dependent antibiotics, which of the following is true? Oh, geez. See, post-antibiotic effect occurs when levels are above the MIC. These drugs require frequent dosing. Dosing decisions can be made from levels after one dose being given, or peak level should be used to measure efficacy. All right, what do we think? Yeah, so those drugs require frequent dosing. Why is that? Yeah, it helps keep it above that level, that MIC, for longer periods of time, right? At least 40 to 70% is ideal in most of those cases. The longer the better, though. Which drugs are going to have the post-antibiotic effect? Concentration-dependent killers, things like gentamicin and the aminoglycosides are good ones for that. Dosing decisions can be made after one dose. Why not? You're typically not at steady state at that point yet, so you usually got to give it some more time. So think back to how we were looking at vancomycin. That's a really good example of a time-dependent antibiotic that we do therapeutic drug monitoring on. Remember, we do troughs, and we wait till before the third or fourth dose because that gives us time to get to steady state. Now, why do we measure troughs? Because we want to make sure we're above that threshold to make sure we're still killing it. So, for instance, if we are shooting for a level of 10 to 15 mics per ml, we want to make sure that the trough is above that or right at 10 to make sure we're getting good antibiotic activity. Okay. Peaks we don't care so much about. It's really more that accumulation of the drug that we worry about in terms of toxicity and the efficacy. Okay. Which medication would have a relative contraindication in a patient with hypertension? Be acetaminophen, diphenhydramine, pseudoephedrine, or oxymetazoline.
Which drugs have concentration dependent ones?
Immunoglycosides are a good one. Fluoroquinolones, stuff like that.
Okay. Got it.
And the answer is? Yeah, pseudoephedrine. Yeah, so looking at relative contraindication, so it's not something you cannot use for those patients, but something you may want to consider not using. So acetaminophen, diphenhydramine shouldn't really have much appreciable effects on the blood pressure. Oxymetazoline, why? That's a vasoconstrictor, but why am I not putting that on the list? It's pretty local, right? Certainly there could be some people who may have a little bit more dramatic effect, but if it's a patient, as long as they're not like an hypertensive urgency or something like that, they're probably fine to get a couple of days of Afrin, right? Pseudoephedrine, on the other hand, how is this normally administered? It's oral, right? It's going to be systemic acting. You're going to see blood pressure go up. So if they're uncontrolled, this may be someone you don't want to use that for, right? They come in and they're on blood pressure medications and their blood pressure is, say, 115/75. They may be okay to get it, right? You may want to monitor and have them check their blood pressure after taking a dose, but that's why it's a relative contraindication. It's not absolute, right? Okay. Which medication is most likely to cause tinnitus as an adverse effect? Be azelastine, ibuprofen, aspirin, or acetaminophen. I tell you how I figured out the the pronunciation for that. I had an audiologist who was a next door neighbor of mine one time, and I said, "What do you say, tinnitus or tinnitus?" And he goes, "Tinnitus." And I said, "Okay, I'm going to say that from now on." Figure if the audiologist is saying it that way, then I'm going to say it that way too.
Yeah.
One time I was teaching a class of PA students, and I said angina, and they said, "Don't you mean angina?" And I said, well, either way I think is fine. They're like, well, the only other person that says that is a cardiology person that taught us. And I said, well, wouldn't you listen to the cardiology person? I said, oh yeah, I guess that makes sense.
But they're not like English experts.
It's true, we're not.
Yeah, it really doesn't.
It honestly doesn't matter, yeah.
Like, the professors here mispronounce it. But they know.
How dare you assume we're wrong?
They know. Most of them are professors.
Anyway, so which medication that causes aspirin is the big one, right? Some people even get this at therapeutic doses, and it's not necessarily just like a ringing in the ear. It could just be a kind of a muffled hearing, kind of a muffled sound sort of effect there. I remember I had one patient who was calling the poison center, and they had overdosed on aspirin intentionally. And they're calling that they got cold feet, and they got scared, and they were calling. And it was so interesting because I was trying to talk to them, and I was trying to walk them through it, and the whole time they're like, what? They couldn't hear me because the tinnitus was so bad. And so eventually I had to call 911 just to come pick them up because I wasn't able to communicate with them at all. So, yeah, it's a sad case, but, it's something I got to deal with.
Is aspirin that much more likely than ibuprofen to cause tinnitus?
Yeah, it's pretty typical with aspirin. Ibuprofen may have some incidents, but it's not as common as I'm familiar with.
Okay.
Any other questions?
Yeah. Are all other salicylates are also or cause tinnitus, or is it just?
Yeah, so if you have like methyl salicylate or anything like that would also cause that potentially. Yep. Mm-hmm. Yeah, but azelastine, ibuprofen, acetaminophen, not really known for causing that. That's certainly one of the big things we'll ask about, especially if I have someone with an aspirin overdose. That's one of the things we'll try to ascertain. Gives us a clue of like, you know, just how much they might have on board in terms of the effects that they're experiencing. Anyone know what acid-base disorder you get first with an aspirin overdose? Respiratory alkalosis, actually. It actually stimulates the respiratory drive, and so it actually causes them to become tachypnic, and they'll blow off a lot of CO2. So we had one case where a patient came in, we were suspecting an aspirin overdose. We weren't sure if we needed to treat or not, and then we were going to get a level to tell us if we needed to do something about it. And the lab said, oh, well, the lab's down, we can't do the aspirin level. And so we said, well, can you run an ABG? And they said, yeah, we can do that. So we got an ABG, and sure enough, it showed a respiratory alkalosis. We knew there must be enough around to actually do something about it. So that's the first thing you'll see. There's a whole host of other things, but we can talk about that some other time. Anyway. Which of the following medications has coverage against Pseudomonas? The Bactrim, Zyvox, Amoxicillin, or Maxapine. Changes in. Very good. Yes, cefepime would be correct here, right? So this is kind of cefepime falls in which category of cephalosporins? It's a 4th generation, right? Is there any 3rds that do it? There's ceftazidime, but remember that one gets a lot of resistance to it, so we don't use that one clinically. Cefepime is really the go-to in terms of anti-pseudomonal cephalosporins. Penicillins, which one could I use? Piperacillin, tazobactam, very good. What other classes could I use that has pseudomonal coverage? Fluoroquinolones can be kind of plus or minus. Levofloxacin for sure, but sometimes Cipro might be a little plus or minus. You know, moxifloxacin might be plus or minus. But again, think about the route that you're administering, right? Moxifloxacin in the eye, you can get really high concentrations. That's great for Pseudomonas, right? Think about VisionBlue drops or something like that. Yeah, tobramycin will certainly cover that. So aminoglycosides would do it. What else do we have? Polymyxins would cover it. What else comes to the top of my mind? Got any other ones? Carbapenems would do it, yeah, for the most part, like your meropenems, imipenems. Anything else? Did you say something? Not typically macrolides. They would not cover Pseudomonas typically. Yeah, so those are the main ones, right? So again, I ask a lot about MRSA and Pseudomonas coverage. You probably should know those sorts of things because you want to know what covers those particular bug. Okay. The last question, which of the following is a potential adverse effect of using prednisone? Could we see viral infection, hypoglycemia, dehydration, or hypotension? Side effect of prednisone. Ask yourself, what kind of drug is that even?
Oh my gosh. I see one answer that
So right now, like all of these facts and drugs are all kind of like jumbled up in a big spider web kind of mess. But you got to start pulling it apart so you start to see the connections a little bit more clear, right? Because you got to switch modes pretty quick. You got to think, okay, well, I was thinking about antibiotics now, and I got to switch over to another class of drugs altogether. Now I got to switch to ophthalmology, and I got to switch to this. Again, that's medicine, right? What do I use prednisone for? Anti-inflammatory, right? Let's see. So the correct answer, viral infection. So let's look at why that is. It's very exciting. So why do you get a viral infection? Why is that risk higher for a viral infection with prednisone than some of these other ones? Yes, right. So remember, prednisone falls in which category? What class of drugs? It's a corticosteroid, right? It's a glucocorticoid. And so you're going to find that immunosuppression is one of the things it causes because it's an anti-inflammatory, right? It's it's going to slow down that immune system to some degree. So viral infection, bacterial infection, all those risks go up with more chronic use. What does it do to your blood sugar? Increase, right? So glucocorticoids, a stress hormone, so you're going to find that increases blood glucose because it stimulates gluconeogenesis in the liver, right? How about dehydration? Why don't you see that? Hmm?
Do you absorb more?
You actually end up reabsorbing more water from the kidneys, in fact, right? So you can actually see edema develop because it has some aldosterone effects. You guys remember aldosterone? Now remember that's what we call a mineralocorticoids. It's kind of the flip side of the glucocorticoids. It's going to cause more water and salt retention. So typically, if anything, you can see edema develop and hypertension in patients who are more kind of at risk for that. Okay, so usually patients who have kind of long-standing problems with these issues anyway. So your diabetic patients more likely to see the hyperglycemia. CHF patients more likely to see the edema and the hypertension there, right? So those are things you want to watch out for. Okay. So, any questions on that? Who's our winner? Sarah C. Very good job. We're not going to clap for you.
Crack eye.
Very nice, very nice. Who's crack eye? Very nice, fantastic. And then weekend yet? Almost. We're almost there. Good job. You have one more class after me, and then you're
I
good.
got more questions right.
So, any questions I can answer for you so far for the test? The test is validated. It's been written. It's been reviewed. It is good to go. It's in Canvas, just waiting for you. Monday morning, 8:30. Yes, ma'am.
So will it be more like question styles like this, or more vignettes?
It's going to be a mixture, so I kind of like a character limit with these, so they're a little bit more straightforward for these kind of questions, but the same facts you're looking for, right? You're still looking for the same, what drug is going to cause this side effect? What would be the first line choice for this type of, infection, all those kind of things there. What drug would be best for this particular, effect the patient's experiencing, right?
Can you go over again when you would use a leukotriene inhibitor over mast cell stabilizer?
So do you mean more like the antihistamines? Yeah. So basically, remember that a mast cell stabilizer is basically going to prevent the mast cells from degranulating at all, right? So if you're already having an acute allergic reaction to something, the mast cells have already degranulated. So is it going to do any good to stabilize them? Not really, right? So those are better for more kind of chronic use as sort of a controller medication, almost like you'd use a daily nasal steroid to prevent nasal symptoms, nasal congestion and things like that for allergies, right? Because it's kind of a preventative medication. On the other hand, though, once they've degranulated and released all their histamine, that's when you want to go ahead and use something like an antihistamine, a zelastine or something like that to block those receptors. Make sense? Very good. See if there's any questions on the... I didn't even open up the... Is there any sticky note questions? Well, let me look. I'd hate to ignore those people. Let's see. Here we go. Very good. Would Cipro be used for Pseudomonas aeruginosa in the eye? Ofloxacin is... I'm trying to think. Is there a Cipro eye drop? I believe there is a Cipro eye drop, so I think so. Yes, I would go with that. Be reasonable. If someone has a toenail fungus, would they have to throughout their toenail polish to prevent future infections? That's a good question. They would not throw it out, but throw it out. But that's a good question. I would err on the side of yes. Just go ahead and get rid of it. Get some new polish, I guess. You got to let those nails breathe anyway. Don't cover them up with nail polish, Should we expect a lot of dosing calculations on the exam? Not on this one. I don't think there's any dosing. Yeah, there's no calculations. That'll come up more when we hit the peds section next semester. So, yes. Yeah, the calculations are mainly going to be like on your prescriptions, assignments, and whatnot, okay? When you're saying, I'm probably not going to cover this for the exam, what are you referring to? Couldn't hear. Sorry if dumb question. I have no idea what I was talking about. If I even said that. I've already forgotten 2 minutes ago, so.
It might have been the 30th.
Oh yeah, don't know the ribosomes, which ribosomes are inhibited by which group of medications. Just know if it inhibits protein synthesis. That's really the biggest thing I want you to. That's the level of depth I need you to get to on that sort of topic. Okay. Any other questions for the exam? Yes, ma'am.
So some of the antibiotics covered there was 25 bacteria listed, Klebsiella, all of those. Do you want us to know the main Pseudomonas, MRSA, VRE?
I want you to know the broad stroke. So again, if I said something like this covered broadly anaerobes and gram-negatives or anaerobes and gram-positive, I want you to know that. And then those specific bugs we mentioned like C. diff, things like Pseudomonas, MRSA, VRE is probably a good one to know. Those kind of things, those kind of standout sort of bugs, those are the ones you probably should focus on, right? And again, each individual indication is not going to be something I'm going to quiz you on specifically unless it's like coming from the ENT section. So since we specifically talked about AOM, sinusitis, strep, those are things you do need to know in terms of like what drugs you're going to be using for those indications. Okay. So drug selection, knowing about drug interactions, knowing about drug side effects, all those kind of things you should know about. Okay. Any other questions? Okay, if not, I will see. I'm sorry. Oh, there's another one on there. Very good. Can we use Exam Master for pharm? Yeah, sure. Use whatever you want. There's also, if you go onto the library website and you go to, so there's Access Medicine and then there's Access Pharmacy. Both of those will have textbooks that you can pull some questions from. And again, they're not going to be the same styles. My questions oftentimes are probably a little bit more difficult, especially if you're looking like Goodman and Gilman's or something like that. It's a little bit more like in the pharmacy realm sort of things, but they can still be valuable to look at some of the feedback on why something's right versus why some of the other answers are incorrect. So that's a good reference as well. So.
Is the person asking that question asking where you can find it?
If you are, those can be found in the PANTS questions. Those are difficult because you kind of have to go like into the individual organ section. So you might want to like look in the ENT and just find which drug questions you have associated with that. Like USMLE step 2 and 3 are good ones to look at. I don't think any other good ones. I'm sure even if there's a pharmacy database in there, look that up too. Like why not? You know, it's going to have more drug specific questions.
The Exam Master was very hard to use for pharmacy.
Yeah, because it lumps in all that other stuff together.
And even if you type in the word drug, it could ask you something that's completely non-pharmacological.
Yeah, so you might just have to pick and choose on those sorts of things. So it's difficult, but again, that's how your PANTS is going to be. You know, like the drug component is just one aspect of the whole thing overall. You know, but certainly go to Access Medicine and Pharm and pull some questions from that. That will be much more specific to our purposes. So you can go to like so Goodman and Gilman's is good out of Access Medicine, and then Pharmacotherapy. That's the title of the book. You can find that in Access Pharm. That one's a good one too. Those are in your syllabus. So you can find the titles of those there. Okay. If nothing else, I will see you guys next time. Good luck on the test. You'll be great. Who reviewed the exam? Who did review? Professor Austin did. Dr. Austin did. Why does that matter? The only thing she said when she handed it back was, wow. So, I don't know if that's good or bad, but let's see. Just kidding.
Yeah.
Just messing with you. Just messing with you.
What was your average on the first exam last year?
It was pretty good last year. Mine are usually ranging from the 88 to 89 range. I might have a standard. I'm exceptionally pretty consistent in my results there. Every once in a while, 87 might be 91, but usually 88, 89 kind of range there.
What are your standard deviation of it though?
I gotta look. That changes a little bit. I said maybe a point or two. You guys will do fine, right? So most of you are probably pretty apprehensive about the whole thing, right? Most of you probably heard how my tests go, right? Okay, so people tend to overstudy for this one, which is okay. I encourage that. And then they go, wow, that one was super easy because I overstudied for it. And then so the next one, then they go, this won't be so bad. And then they don't study enough for that one. It's all cardio, and then they sink themselves. So overstudy for all my tests, and you're fine.
Why is the price?
That's why I put it on Mondays, right? You have the whole weekend. Just think about pharmacology. Got it? Okay, nothing else. I'll see you guys next time.